Hello everyone, welcome to another video of the NEET PG Coach. In this video, we'll be talking about the arterial pulses. So in your exam, you might be given a pulse waveform and you might be asked to choose what type of waveform, what does it represent. So here you can see these different pulse waveforms and this is the normal pulse waveform. Here you can see that there is a sharp peak and also a downslope. And you know that the duration between S1 and S2 is systole, and after that it's diastole. So you can see between systole and diastole there is a notch. This notch is called the dichrotic notch. So this is the normal pulse waveform. And there might be certain pathologies where you might have a different type of a pulse waveform. And you might be asked one of these questions, you might be given a case scenario and you might be asked to pick the pulse waveform which is associated with the pathology. For example, you might be given something about aortic stenosis. You know that aortic stenosis is known as sad disease. Sad disease because patients have syncope, angina, and dyspnea. So they might give you a case scenario describing all these. They might give a pulse pressure which is about 80 and 60 and say that it's a 65-year-old male. And everything. And they might ask you, they might give you clear indications of aortic stenosis, and they might ask you to pick the pulse waveform which is associated with that. In that condition, you'll have to pick this. So the pulse waveform associated with aortic stenosis is known as pulsus parvus et tardus, which literally means slow rising pulse. Slow rising pulse with a delayed upstroke. And sometimes it's also described as anacrotic pulse. Anacrotic pulse means it has no peak. So here you can see that it's a very slow rising pulse compared to the normal one. It's a very slow rising pulse and there is no peak. Sometimes there might be a delayed peak here. Instead of the peak coming here, there might be a delayed peak. So this is a type of pulse waveform that you see in aortic stenosis. And there is another type of pulse called pulsus bisferiens. Pulsus bisferiens. So here you can see two peaks. So here you can see two peaks. 1, 2, 1, 2, 1, 2. If you have two peaks like this, it is a type of pulse known as pulsus bisferiens, and you might be asked to pick the pulse waveform which is associated with that. And in those conditions, all these three things fall under pulsus bisferiens, C, D, and D. So if you look at C, you can see that both peaks are within systole, and also in D, you can see that both peaks are within systole. But whereas in D, you can see that one peak is in systole and one peak is in diastole. And you can see the dichrotic notch between systole and diastole. So if you see that both peaks are of similar amplitude and they occur in systole, and that type of a pulsus bisferiens is seen in aortic regurgitation. If you see both peaks in systole, but one peak is of higher amplitude and the other peak is of lower amplitude, that is also a type of pulsus bisferiens. It is seen in HOCM. So you know that in HOCM there will be asymmetric hypertrophy of the interventricular septum and SAM, systolic anterior motion of mitral leaflet. So both these conditions cause a dynamic obstruction of the left ventricular outflow. So this leads to this type of a pulse waveform. This is a variant of pulsus bisferiens where the amplitude of one waveform is high, the other waveform is low. The first waveform is known as the tidal wave. The next one is known as the percussion wave. Okay, you don't need to know about that. Just know that this is the waveform that you can see in pulsus bisferiens, which is associated with HOCM. And see another type of pulsus bisferiens you can see after a condition called IABP. IABP stands for intra-aortic balloon counterpulsation. Intra-aortic balloon counterpulsation. It is basically done after severe MI to buy the patient some time before some definitive intervention like PCI or CABG can be done. So what it does is like a catheter is inserted and it's passed all the way into the aorta and it is inflated. So once the catheter is inflated, it keeps the aorta open during diastole. So basically there is blood flow, blood still coming into the coronary arteries because during diastole you know that the vessels collapse. But because this balloon is inflated, there is no collapse of the aorta and perfusion is maintained for the coronary vessels so that it buys the patient a little bit of time before some definite intervention like PCI or CABG can be performed. So they've noticed that after performing IABP, intra-aortic balloon counterpulsation, um, they had measured seen the pulse waveforms and they found that this is the type of pulse waveform which you see in that patients. One peak occurs in systole and the other peak occurs in diastole. Okay, so we've seen about pulsus parvus et tardus, normal pulse, pulsus parvus et tardus, and the three variants of pulsus bispherians. Moving on to the next type of pulse is pulsus paradoxus. Pulsus paradoxus is actually a misnomer. I call it a misnomer because it is an exaggeration of a normal phenomenon. Normally, when a person breathes in, there is going to be an inspiratory fall in blood pressure. Inspiratory fall in BP is always going to be there, but it's going to be less than 10 millimeters of mercury. If it is more than 10 millimeters of mercury, it can be appreciated clearly, and in that condition we call it as pulsus paradoxus. So nothing paradoxical about pulsus paradoxus. It is just an exaggeration of the normal phenomenon, and it's actually a misnomer. It is seen in these conditions. You need to know about these conditions. For example, you might be asked a question um, asking pulsus paradoxus is seen in all the following conditions except. So you must be able to like rule out the odd one. So it is seen in cardiac tamponade, massive pulmonary embolism, tension pneumothorax, severe COPD, and hemorrhagic shock. Okay, and the reason for pulsus paradoxus is see the underlying pathophysiology is during inspiration there is increased filling on the right side of the heart, but decreased filling on the left side of the heart. So why is that? So during inspiration, there is a decrease in intrathoracic pressure, and this draws the blood into the right side of the heart. And because it draws a lot of blood to the right side of the heart, there will be increased filling of the right ventricle. So there is a phenomenon called interventricular dependence. Interventricular dependence, meaning to say that changes which occur in one ventricle will affect the other ventricle. So I said that during inspiration there is increased filling of the right ventricle. So as the right ventricle distends with blood, it leaves less space for the left ventricle. Because you know that the heart is contained inside the pericardial cavity. As the right ventricle distends, it leaves less space for the left ventricle to distend. So consequently, there will be decreased filling of the left side of the heart. So cardiac output is determined by the left ventricular output. Okay, cardiac output is directly proportional to the left ventricular function. So the filling on the left side, if it's decreased, obviously the cardiac output will be low, and you know that cardiac output is directly proportional to blood pressure. So as the cardiac output falls, the blood pressure also falls. So that is actually a normal phenomenon, but it is exaggerated in certain conditions. And these are the conditions: cardiac tamponade, pulmonary embolism, tension pneumothorax, severe COPD, and hemorrhagic shock. Okay, it is an exaggeration of the normal phenomenon. And the other type of pulse that you need to know about is pulsus alternans. This is nothing but a beat-to-beat variability in the amplitude of contractions. So if you see the pressure tracing, you can see that this is of higher amplitude, this is of lower amplitude, higher amplitude, lower amplitude, higher amplitude, lower amplitude. So there is a beat-to-beat variability in the amplitude of contractions. And this is seen in severe left ventricular systolic dysfunction. And it is due to changes in calcium and action potential duration with every beat. With every beat, there might be changes in calcium and action potential duration, and this leads to pulsus alternans. Sometimes this may be accompanied by T-wave alternans. T-wave alternans is nothing but the beat-to-beat variability in the amplitude, shape, and timing of T waves. So if pulses alternance is accompanied by T wave alternance, it might imply that the patient is in impending cardiac arrest. I mean to say the patient might go into cardiac arrest at any time. So this requires emergency intervention to find out the cause. Okay, so that brings us to the end of this lecture about pulses. I'll see you in the next lecture. Thank you.